So the outline of my session is what are three-part and five-part analyzers very broadly. The principle of three-part analyzers, which one to use in a laboratory, the utility of numerical and graphical data, and I'll focus on the three-part. Dr. Archana will cover the five-part, and I'll end with limitations of three-part analyzers. What I'm not going to talk about is five-part analyzers and their scatter plots, instrument-specific terminologies and flags, and theoretical jargon that you'll find in books and other sources. So there is a tendency of some labs to look down on smaller labs that have three-part analyzers. So the three-part analyzer has a role in itself, so does a five-part. You have to work together in a way. We need to understand what this one offers and what the three-part can do for you. It's almost like a Mercedes comparison with a three-part, which is a nano. So it'll go in huge traffic, it'll cover your distances, it'll take you where you want to go, maybe with a slightly slower speed, while the Mercedes offers you more comfort and more amenities that way. So as Dr. Archana will cover a five-part, you will see the five-part definitely offers more. But for some scenarios, a three-part is good enough. So why do we call them three-part and five-part? So that's pizza sliced into 3 and 5 here. So a three-part virtually actually gives your WBC differential in 3 parts, so to say. Your major populations are neutrophils and lymphocytes, and a mixed population of eosinophils, monocytes, and basophils are always suspect. So you can, even if you forget about basophils being given very accurately by analyzer, that's fine, because basophil is not a key cell of any diagnostic importance in most settings. A five-part, typical five-part gives you neutrophils, lymphocytes, monocytes, eosinophils, and basophils fairly accurately. So you can depend on a five-part for most differentials unless abnormal populations are seen. And the refinements keep on increasing. So if you look at the three-part, five-part, and then go on 6, 7, 10 parts, they keep on offering you more and more. So you could have atypical cell given as separately, fragmented cell count given separately, immature granulocytes, RBCs, or even blasts enumerated separately. And I'm not joking, but yes, maybe someday we'll have a 12 or even a 15 part, the way automation is going. So when to use three-part analyzers? Look at this analyzer, which is a smaller version for small laboratories, which deal with usually less than 100 CBCs a day, even 20, 30, 40, that's fine for a three-part. It'll be tough to handle a workload of 800 plus or 500 plus on a three-part, although you can push it, but you compromise on its life usually. And if cost is an issue, five parts are very expensive. They range anywhere between 15 lakhs to 30 lakhs or even more. The three parts will come within 5 lakhs in most scenarios. If you're in a community setup with a peripheral health center, not much of advancements available there, go for a good three-part that will serve your function well. Or if you're doing only single tests, and that's not, most labs don't do single tests, we know these days, CBCs only. But if you're handling CBCs and you get a request on a single test, only a hemoglobin, TLC or platelets, you're running a five-part, then having a three-part to do this is more economical. You can also use a three-part as a backup for a very expensive or a high-end five-part instrument in your lab. If it breaks down or is undergoing long servicing, you can use a three-part to get your job done. For blood banks, to deal with only hemoglobin or platelets, to decide for decision on bleeding a donor for apheresis for platelets or even otherwise, you can use a three-part. An accurate CBC report is an outcome of flags, histograms, the numerical data that we get, and the blood smears. So I'm going to focus on the numerical data and the histogram that the three-part generates. We owe it to this man, Dr. Wallace Coulter, who gave us the Coulter principle, in which basically you have two electrodes, an external and internal, positive and negative. There is current flowing through with the diluent as a medium. And whenever a cell passes, we get to know which cell and how many cells have passed. So let's look at some cartoons or animations. So electrolyte solutions like the diluent in most analyzer. So when your analyzer is connected and on and ready to run, it's actually the circuit is complete. So you have an electronic circuit complete through electrodes within the diluent. Now blood cells are poor conductors, so when the circuit is complete and the current is flowing, you put in a cell, let's say a red cell, and the current is cut off. And the red cell, we know, and even the white cell, all cells have a lipid membrane, so they are poor conductors. You put in a neutrophil, again the current is cut off. So we can measure the current cutoff as resistance or impedance, and that is what most three parts work on. So let's see when a red cell passes through the aperture, that's a positive electrode and a negative. This is the sensing zone, and the hydrodynamic focusing system for the diluent ensures that one cell comes in at one time. So let's say this volume comes in and you get a big impulse, a smaller cell, a medium impulse, and a very small microsite, smaller impulse. So from the number of impulses, you've sorted out how many cells have passed, and from the volume displaced or the impedance, the current cutoff, which is the resistance, you know what is the rough size of the cell. Same way a white cell, neutrophil bigger cell, a smaller lymphocyte, and a still smaller small lymphocyte gives you a smaller impulse. So in a histogram that you see for any three-part analyzer, WBC, RBC, or platelets, so when you look at that, if you look at the difference, RBC and platelet histogram, except for the labels, seem alike, except that the volume is different. So platelets are small, volumes are small, RBCs are bigger, volumes are large. But a WBC histogram is divided into zones. And that's important. We'll cover that when we go to the WBC histograms specifically. We know that the WBCs are nucleate cells and the RBCs and platelets are anucleate. So it makes sense to count them together. So this is what is happening within the analyzer. Although we see the histogram separately, the platelet and the RBCs are actually being counted in one channel. So the instrument is fed in a pre-programmed software that till this volume, call it a platelet, and in larger volumes, call it an RBC. Which also means that large platelets, which fall into the zone of RBCs, can be counted there, and fragmented RBCs can be counted as platelets when they fall into the smaller zones. So all the histograms at all times in any sample are actually trying to tell us something. So a lot of people also look at my instrument is this make, yours is a different make. We may have 3 parts, but maybe 7 makes across laboratories. We must remember every instrument has its own personality. Once you work with it, you'll know how it functions. Broadly, 3-part analyzers function very similarly. The technology is impedance. You get your 3 histograms, you get some numerical parameters. They're fairly similar. It's very important that the lab hematologist is friends with the analyzer. Do not leave it to the technician only to run and give you a printout. We must break our heads with the analyzer when there is troubleshooting required or unusual results are there. You'll find your answer, definitely, and sometimes a diagnosis. So this ad is which says "Har ghar kuch kehta hai." Now I always feel that her analyzer bhi kuch kehta hai. You just need to understand it. So let's look at the 3-part analyzer. So if you see again, any standard 3-part analyzer will give you these histograms and a printout with numerical parameters. So we deal with numbers and we deal with histograms. So how are histograms generated? So let's say lots of cells passed through the aperture in the red cell column or channel and the WBC channel. So the red cell channel would include platelets along with the red cells. And same with the WBC, you get all the red cells are lysed and only WBCs passed. Whichever the cell, when the volumes pass, so a small cell, medium cell, large volume cells, this is what happens. The instrument picks up how many cells have passed and what is their volume. And then it collates the volume, arranges them, and then you get your mean volume through this channel, right? And this is true for all histograms generated, WBC, RBC, or platelets. A word about discriminators. So this is a normal, let's say this is a normal histogram here. That's a lower discriminator and the upper discriminator. For most normal cell populations, your histogram should be within this. If it touches here or does not touch the baseline, expect a problem. The instrument is not able to understand normal populations. It is either experiencing interference with the lower discriminator, lower volumes, or in the higher volumes. We'll see some examples as we go along. So there's a lower discriminator error where you have a histogram, but your RBC histogram on the left limb is not touching the baseline. So this could be platelet clumps, red cell fragments, giant platelets, or very small microcytes that are interfering there. So looking at a histogram which is abnormal is usually a clue to what to look for in the peripheral smear. A word about moving thresholds. So that's a platelet histogram, very normal, and that's the cutoff. So beyond this, platelet is not counted. It goes into the red cell count, which doesn't make much of a difference. When you look at this histogram, the platelet histogram is not touching the baseline. This is expecting interference at the upper discriminator. Now your platelet count is likely to be erroneous. The instrument is trying to move this threshold to fit this population, which is abnormal. So expect interference and expect an erroneous automated count. You need to see the smear of these two cases very carefully. You will find giant platelets and large platelets. which will not be counted by the instrument, and you may have to give an incremental manual count. So let's look at some common hematological disorders. First, red cell disorders. That's a normal histogram. You have your regular parameters, your indices this side with RW, platelet counts, MPV, and your regular parameters that we are familiar with. That's an automated differential. So like we said, we had a three-part differential. So what is it giving us? It's giving us mainly a lymphocyte population and a granulocyte population. And in this one, it calls it monocytes. But usually this is mixed. And in this is this zone in the center. So your lymphocytes fall here, your granulocytes are in the higher volume zone, and your monocyte eosinophils, and the companies do say basophils, tend to fall in this zone. So that's how you interpret a normal histogram. That's WBC. For RBCs, the volumes. And for platelets, again, a cutoff is usually 20, 25, or 30, depending on the instruments. So this is a case to begin with. Hemoglobin is 4. Indices are very low. It's a microcytic hypochromic picture. REW is high. So as you will know, this is a classical case of iron deficiency anemia with this picture. Why not a thalassemia? The anemia is very severe. The REW is not that high. Thalassemia will take you usually beyond 25, even in 30s. So this seems like a very severe iron deficiency anemia. If you look at a histogram, it seems to move to the left compared to the normal one. We'll see a comparison in the next slide coming up. So that's iron deficiency anemia. Another case, is there anemia? Actually, no. This is a female patient, 12.3, no anemia. The RBC count is much higher than what you expect, even with a hemoglobin of 12. You would expect maybe 4.5, at max 5 million, that's 6.35 million. And with a hemoglobin of 12.3, you have gross microcytosis, but your REW is normal. So this is a classical case of beta thalassemia carrier, where if you look at the Menzer index, which is the MCV divided by the RBC count, you'll get less than 10. So that's a classical thal trait picture. In this case, if you look at the histogram, again, it's shifted to the left, and I'll give you a comparison with IDS soon. So that's beta thal carrier or trait. Another case, so we are still in the microcytic zone, very, very severe anemia, very low RBC count. Your MCV is again low. Look at the REW, 28.3. Now, just looking at this number, even without a histogram, you would expect a lot of anisopoikilocytosis in your smear. So the volumes are very, very different, which is what you see in a classical beta thal homozygous. So that's a beta thal major. Look at the RBC histogram, very, very wide. If you go back, look at the thal trait one, very narrow. So this is very wide, and this actually tells you what the film is likely to show, which is going to be marked anisopoikilocytosis with gross microcytosis. So with this very high REW, this set of parameters actually is very suggestive of beta thalassemia homozygous. So when we compare, that's a normal RBC histogram. Look at iron deficiency anemia, that's beta thal trait, that's beta thal homozygous. So if you draw a line here, you can very clearly see the shift to the left, gross microcytosis, and the width of this histogram tells you anisopoikilocytosis in the thal major case. Beta thal versus iron deficiency, narrow peak. So again, the degree of poikilocytosis is not much. That's why the normal REW, here REW was 20. So 40, 20, and 28. It's reflected in the histograms. They do speak a lot. So that's their comparison. So going on to macrocytosis now. You have anemia, yes, 7.3. MCV is high. REW is high. So again, expect poikilocytosis. With a 7 hemoglobin, your RBC count is pretty less, which you would expect if you have ineffective erythropoiesis. So 1.83 with 7.3 is very, very less. So you would probably think this is megaloblastic anemia looking at the REW and the degree of anemia. So that's megaloblastic anemia. And again, if you see, look at your volume of the cells, the proportion of cells beyond 100 femtoliters. So that's why the MCV is higher side. So classical megaloblastic anemia. Another case, look at the MCV first. I'll take you to the MCV first, 115, higher than our last case. REW is normal, but look at your hemoglobin, 15.1, no anemia at all. So this is again classical non-megaloblastic macrocytosis. The commonest cause in India you will find is alcohol consumption. So it is only a membrane problem. The membrane collects excess lipid and the contents, so it expands, but your hemoglobin remains normal. So this is non-megaloblastic macrocytosis. Look at your histogram, the width beyond 100, enough, 40% is beyond that. Again, when you compare these two, so look at the width on the megaloblastic anemia, look at the width on non-megaloblastic. That's why the REW is normal. Okay, what about using the indices? So let's not be mean. Look at this case. Hemoglobin is 10.7, mild anemia. If you look at the indices alone, that's 89 to 29.6 and so on. Now this means you got a normocytic normochromic anemia, and that's the importance of the REW. So if you look at mean parameters, those are normal, but your REW is high. So if you look at a histogram, it seems wide. Yeah. So this histogram is wide because there is a tug of war between the microcytes and the macrocytes. So what is happening is the microcytes are pushing the histogram to the left, the macrocytes are pushing it to the right. Your net effect on the mean counts is normal, but your RDW, if you notice, was 20. So the RDW is telling you it is not everything fine. There are populations which are of different volumes. So if you look at this comparison now, your normal histogram versus this one that we saw, it's widened, and you have a significant microcytic population. On the other side, we have a macrocytic population. So they are cancelling out each other's effect, and hence the mean is coming out to be normal. So look at the REW, do not interpret with only indices. Okay. In this case, you have mild anemia again, MCV is within normal, 95. MCHC is to be looked at here. MCHC is very rarely high. If it is high, look at the possibility of spherocytes, stored blood, or artifacts. So that's 37.2. Look at the RBC histogram carefully. The trail on this side seems to be odd compared to the normal one. So this is a case of spherocytosis. Remember, this MCHC increase and the shoulder on this side will be affected only if you have significant, usually about 20% or more spherocytes in your sphere. We know that mild HS may not have that many, and that might not show any abnormality on the histogram. Again, a comparison with the normal histogram. If you look here, there is a shoulder on the lower side. So the small spherocytes are being plotted here. That's spherocytosis. Now, we know camels have one hump, but there are two humped camels. So if you look at a histogram and you find this pattern, a double hump here, this usually means a second population that has come fresh from outside. And this is recent blood transfusion. So look at the MCV, 70, but look at the REW, 28. With this MCV, if it is iron deficiency anemia, I would expect maybe 17, 18, max 19. So this tells you the populations are extreme in your sphere. So when you look at this is your microcytic element, and this second hump that you're seeing is most likely the transfused cells. You give it 4 or 5 days or a week, and usually these two will merge and give you a single histogram. So fresh transfusion will give you a double lump very clearly. Traffic jam nobody likes, neither does our aperture in the instrument. So when there are lots of RBCs coming together, the instrument gives up. And sometimes this is the diagnosis or the clue for this. So let's look at this example. The most important problem lies here. Your hemoglobin is 3.5, and we expect the hematocrit to be 3 times roughly, which is 10 plus. That's similar, 3.4. RBC count multiplied by 3 should be hemoglobin, even that's not right. So the rule of 3 in hematology has been violated here. How are our indices calculated from these 3 parameters? So all our indices here are actually erroneous. You can believe an MCV of 110, yes, but what about these two? Never ever. So this is a set of bizarre values. So a lot of times the technician will come to you saying the instrument is giving wrong values. And if I see this kind of a printout, I'm very happy you have a diagnosis coming up. Incubate this sample at 37 for half an hour, run it again, you will sort it out most of the time. Indices will come back to normal. So what is happening? This is actually cold agglutinins giving you bizarre indices and a bizarre red cell history. This is almost like a sawtooth appearance. So the aperture is confused with doublets, triplets coming up. So you would expect agglutination seen on the smear, definitely in this case, which will be eliminated once you incubate at 37. So again, in this erroneous report, you have a diagnosis sitting there. Let's talk about white cells. So look at the WBC histogram that we saw earlier. So remember our lymphocyte peak, the mid zone, which is usually flat, and the granulocyte peak. The granulocytes have a higher volume, so they are plotted here. So let's look at the representation of cells on this histogram. You have the lymphocytes, You have the basophils and eosinophils and the monocytes in the mid zone, and then you have the granulocytes right here. Now, you can always argue the monocyte is a larger cell. Why is it sitting here? Eosinophils are larger than neutrophils. Why is it behind in volume? And the answer lies in the way these cells behave when the lyse solution touches them. So the monocyte, although being big, in the presence of lyse, quickly crumples up. The nucleus crumples up, becomes small. The cytoplasm crumples onto it, so the volume after the lyse touches it becomes small. Hence, it is plotted in this zone. Same with basophils and eosinophils. So if you look at volumes before lysing and after lysing, that is how they are placed, size-wise. So it is not as they appear in the smear. In the instrument, the monocytes, basophils, and eosinophils occupy a smaller volume. So again, a look at the normal histogram: lymphocyte zone, granulocyte zone, and the mid zone, which is usually flat or near parallel. So there's a doubt about eosinophils and monocytes. They do give some interference in 3-part histograms, but they are not that reliable. So you don't expect a 30% monocytosis on a 5-part to show up as same or a high mid zone always on a 3-part. There may be some interference, some elevation, but they are not that reliable. So you need to do a manual count always. So then when you look at what is normal, look at this train, you would expect orderly passengers sitting inside versus this one in, I believe, Bangladesh, all over the place, a class with students sitting in nice small arrangement versus a rowdy class. So when we look at leukemias, I'm talking about leukemias only in the WBC histogram because your other white cell populations are easy to pick up. If you have a leukocytosis, leukopenia, that will show up on counts and the histogram. But leukemias, the leukemia cells, the blasts are rowdy cells. They don't behave normally. They don't behave the rules. They don't understand that we have to sit here and here or here. They will choose their own place depending on their size and volume. So let's look at a normal histogram to begin with, and then look at your lymphocyte peak and the granulocyte peak and the mid zone. This pattern is very important because this will be disturbed once you start getting leukemias. So look at these two peaks as lymphocytes and granulocytes and a mid zone or a mixed zone. So mixed, mono, mid. A lot of instruments give their own names to this population. Versus the Everest. This is acute leukemia. When you see a single peak, the normal pattern of this is disturbed, expect a leukemia coming up, or at least atypical cells. So that's normal again. And this is a case where we have anemia. The platelet count is on the lowest side, but still normal. TLC is normal. You have a single peak. So if you see the lymphocyte, so to say, count rises in its zone, but it is falling in the mid zone and just touching the granulocyte zone. There is hardly any granulocytes here. So this single peak tells me there is an abnormal population there, and this was a case of ALL. Now, the mid zone, remember, has been elevated here. So the mid zone elevation, usually you would get monocytes, eosinophils, or atypical cells. Another case. Now, just going back one thing to emphasize, you may have a normal TLC, you can still get 80% blasts. So TLC is no criteria that it cannot be a leukemia. You can even have a 2,200 TLC and still have a leukemia. So another case, again anemia, there is gross thrombocytopenia, TLC is raised, 44,300. Look at this peak again, single peak. So it rises in the lymphocyte zone, it's elevated the mid zone, and it's falling in the granulocyte zone. Not following the rules of this one being here, then being here, and giving you a granulocyte peak here. So this was again a case of AML, acute myeloid leukemia. In comparison to the lymphoid one, if you notice the shift is slightly on the right. That's because of the larger blast size in AML. Another case of AML, TLC is raised, there is anemia, there is mild thrombocytopenia, again a single peak. If you notice a rise and a fall. And a rise and a fall, if you go back to the normal one, should actually be in its own zone. So it rises in its lymphocyte zone, falls there. Granulocyte rises in its own, falls there. So they obey those boundaries which leukemias don't. That's another AML. Single peak, remember our Everest. So in comparison from a normal one, this is ALL and the last two are AMLs, but similar pattern. So remember this, two peaks in its own zone means normal population, and you could have variation in counts, yes. But this kind of a picture means abnormal population. This could be blasts, atypical lymphoid cell, NHL spillover. Even virusites can confuse you sometimes. So you need to basically see the smear to sort it out. Look at this now. Mild anemia, platelet count is normal, slightly on the higher side. WBC is very high, 59,000. So this is a case where if you look at the peaks, the lymphocyte zone is rising and actually fallen here. It has fallen and then climbing. It's mainly a broad, very broad granulocytic peak, and if it reaches very volumes of 300, 400 femtoliters, that means there is enough left shift there. So that's the case of CML. Now the same patient came back on follow-up after 3 months. Look at the picture now. And the TLC had risen to 1,80,000, and this trail appears similar, but now it has raised our mid zone and actually become a single peak, complete total peak. So this was a CML in blast crisis. You can actually pick that up compared to a normal CML background earlier. With the last case is CLL. So this was a sample run in dilution because of extremely high TLC. So don't worry about RBC and other counts or MCHC. That's because of the dilution. Look at your WBC count, 70.6. So if it was dilution in 5 times, so actually 3 lakh plus. Look at the WBC differential here, lymphocyte dominant. Look at your pattern. So the lymphocyte zone rises here, falls within. So because they are a more mature lymphocyte looking, that's a classical CLL. Just 2-3 slides on platelets. So it's a little cell but gives big trouble everywhere. You have a 3-part, 5-part, does not matter. Platelets can trouble you everywhere. So just 2-3 slides to share some things. So if this is a normal count, platelet count. MPV is slightly on the high side but still within normal limits. Platelet count is normal. Histogram is actually normal, falling within the baseline to the baseline before it goes into the RBC zone. A platelet histogram of similar look, but look at the platelet count, 81,000. So the point here is if your platelet histogram is looking like normal, touching the baseline well in time, then your platelet count may be normal or low. You are likely to get a normal platelet count, similar platelet count on the manual count. Which means if the platelet histogram is normal, this automated count is likely to be correct. So expect a similar manual platelet count in these scenarios. Now in this one, the baseline is not being touched. In fact, slightly going into the RBC zone. So expect some large platelets here, or even giant platelets in the higher zone. So here your platelet counts of automated ones may need an increment on the manual count. The worst case scenario, that's normal, touching the baseline. Look at this now. This histogram has gone up, but not coming down in the platelet zone. It's going up and actually spilling all over into the red cell counts. So this count that you're seeing beyond the threshold here is actually going to, these platelets are going to be counted as red cells. So you're going to undercount your platelets if you go by the automated counts. And I've given you the actual counts here. So the automated count was 58, the manual count was 90. Here again 71, almost double. So expect this interference when you look at these the number of platelets beyond the cutoffs or the thresholds, because they are high volume platelets. They will approximate RBC size and be undercounted on your manual counts. So again, the point is look at your histograms carefully. If they are normal and still with thrombocytopenia, more believable. But if they are like this, you will need to make a smear and correct your counts. So the last case, if you look, this is the normal platelet count, the normal appearance of platelets, small, and look at the platelets here. Some are even larger than RBCs. So they will not be counted in your usual analyzers. So what are the limitations of 3-part analyzers? They cannot handle very heavy workload. So if you have a lab with 1,000 plus, a 3-part will give up soon. A poor enumeration of eosinophils and monocytes. This is inconsistent even between different analyzers. If there is gross eosinophilia, like 70-80%, definitely you'll find some interference in the mid zone. But these mild values of 10, 12, even going up to 20 sometimes, may not give you too much of a clue. And basophils are notorious for inaccurate counts in any analyzer. Be it the best 5-part, basophils are not very good in comparison to even manual counts. The manual counts are actually better than most automated basophil counts. So most limitation, the 3-part analyzers have a lesser flagging capability because 5 parts offer you much more of because of their technological advancements. You can have a limited disease subtyping, which 5 parts offer you more. So in 5 parts, sometimes there are patterns of leukemias that are characteristic. APML is one example where some analyzers have a particular pattern where you can say this is definitely a PML coming up. And no enumeration of abnormal cells. So you don't get those numbers. 3-part means 3 parts. Neutrophils, lymphocytes, and those mixed populations. And the most important part is we have a 3-part or a 5-part, does not matter, if we do not use our 2-part analyzer to interpret the 3-part analyzer data. So if you have a 3-part, don't do. It's good enough to sort out most daily problems. So this is the recommendation from me. Please use this 2-part analyzer to analyze any data or any histogram. The moment we forget this and depend on machines only, we are gone. So that was me with my Nano. Over to Dr. Archana's with his Mercedes. Thank you so much.
Thank you, Dr. Naveen. Should I share my screen?
Yeah, please, ma'am. Sure.
Good evening, everybody. Thank you for the organizers to invite me to discuss 5-part analyzers with you. Thank you, Dr. Naveen, for giving an excellent prefix to my talk. It's made my life quite simpler. And let me see if I can prove to you that this is a Mercedes worth buying. So what I'll be discussing in my talk is who needs a 5-part analyzer. Then the basic principles of 5-part analyzers, understanding patterns of histograms, scatter plots, normal versus abnormal, correlating them with flags, and being able to basically, let's say, filter out cases which can directly get reported out and released versus those which would require further intervention. Additional features, of course, like optical and fluorescent platelet counts, parasitic flags, nucleated red cells, and the ability of these analyzers, with the help of certain parameters, to assess the bone marrow status for hematopoiesis. So starting with who needs a 5-part analyzer? We all know that these 5-part analyzers have sturdy machinery, and they can process large numbers of samples in a quick turnaround time. However, are they truly cost effective? So bear in mind the fact that these analyzers come with larger reagent pack sizes, stringent quality control criteria. So the cost of the reagents, the cost of QCs, the cost of, let's say, other consumables of the instrument, all would urge me in direction of it would be far more cost effective when run in a lab which has a higher volume, for obvious reasons. Having said that, I would still like to say that even if your lab does not have a large volume or many samples, but you're dealing with a lot of abnormal samples, for example, if you're affiliated with an oncology setup, then these instruments have a very wide linearity range. That means they can give you reliable results if the values are very low or very high for the CBCs. So it gives you, let's say, more reliable results, and over a period of time, the pathologist also gains more confidence in releasing these results, almost critical values many times, to give you, all in all, a good quality report. So as we said, if you have a large volume lab, that means you're processing, for example, somewhere close to 500 to 1,000, even 1,500 CBCs a day, it becomes almost impossible for you to review even 35 to 40% of these CBCs for smear. It would be still a very large number, and it is hard manual labor, all this put together. So if in my understanding, I feel that in my opinion, that if you're able to spend a good amount of time understanding your histograms, your scatter plots, identifying flags, correlating all this information, you, after a point, would be able to reduce your smears to only those critical cases in which your analyzers shouting out loud and telling you that make a smear. My report or my value may be inaccurate. And that is the aim of this talk, to, bring forth to you such cases, being able for all of us to understand what we need. Then, of course, if you have a large volume of body fluids, analyzers can give you counts as well as differentials. And then to monitor clinical and therapeutic decisions, parameters like reticulocyte count, IPF, immature grands, NRBCs, and parasitic flags, all can be very beneficial. So I'm not going to touch upon principles of measuring cells. I think Dr. Naveen has very beautifully explained the impedance and optical scatter properties, discussing about, let's say, the pulses, and just to reinforce that the number of pulses gives you the cell count, the size of the pulse is the cell volume, and in 5-part analyzers, the sample, once aspirated, splits into various channels. For example, a channel which would lyse the red blood cells by using ammonium salts, and then we measure the hemoglobin using spectrophotometry. Along with that, in the same channel, we also analyze the WBC count. Now, because the red cells have been lysed, they do not interfere largely with your WBC count. So please remember that as we go ahead in our talk. Then another channel for RBC and platelet analysis, one more for differential counts. So the 5-part analyzers have a specific diff reagent. As Dr. Naveen was saying, that the WBC histograms, the cells get lysed by the lysing reagents. Now, these analyzers have managed to come up with an agent which tries to assess these WBCs in their near native form. That means they don't get lysed or destroyed. We try to analyze these cells based on their structures, nucleus, cytoplasmic granularity, etc. Then, of course, the reticulocyte channel. Now, again, I won't go too much into depth here because Dr. Naveen has described the platelet and RBC histograms. They're basically differentiated based on their volume and refractive index. Although they are counted in the same channel, but if you see histograms as clean as this, you're pretty good to go. Now, this is showing you a picture of how a 5-part analyzer screen looks to you. So up here, you can see there is all the demographics for the patient, followed by a lot of numbers, which we call numeric data. Now, this numeric data, some of it is directly measured. For example, the WBC count, RBC count, hemoglobin, and platelet counts. All the other parameters are either calculated or derived. So, for example, from the RBC histogram, we derive the mean cell volume. That's just an example. So we have our numeric data, then we have the graphic data, which includes RBC, platelet, and WBC histograms. Then the differential count, which is represented on the scatter plot. And of course, very importantly, the flags. Considering that we have discussed a lot about RBC histograms, I'd like to start with a poll question. Could you all please put up the answers on the chat box, and the moderator can let me know what you all have answered. You will get 20 seconds starting from this point. This is an RBC and a platelet histogram with the CBC as shown on the side. What is the abnormality in the histogram? Are they dimorphic red cells, giant platelets, nucleated red cells, or parasites? I'll show you the histogram once more. Please let me know once answers start pouring in.
The answers have started coming in, man.
Yeah.
So should I tell the result or should we wait for 20 seconds?
We can wait for 5 more seconds.
Okay.
So I think largely everybody has answered
1.
1 and dimorphic red cells, and you are quite right in that. I agree with all of you. These are not giant platelets because if you see the platelet histogram, is pretty much normal. Both the lower and upper discriminator are largely touching the baseline. The platelet count is normal and the MPV is also normal. So hence, I would not think that these are giant platelets. So just to touch upon dimorphic red cells, how do we enhance this information? So dimorphic could be microcytes, macrocytes, microcytes, normocytes. How are we able to identify which type of red cell populations are causing this dimorphic blood picture? Is it possible by looking just at a simple histogram to do that? Actually, pretty much quite often, yes. Because if you see in these two waves of the RBC histogram, there is a smaller wave. And if you try to look at the mean volume of this wave, for example, suppose it is 65, you know that you're dealing with a small population of microcytes along with a big population of, suppose the cell volume of this is somewhere close to 85 to 90 femtoliters, you know you're dealing with a dominant normocytic population with a smaller microcytic population. So this sort of helps you identify which two populations you're going to be finding in this dimorphic picture. As you can see, the RDW is very high, obviously, and now the clinical scenario of this would be if we've got microcytes, it could be an iron deficiency who's taken treatment and has now started producing normocytic red cells, or it could be an iron deficiency post-transfusion. There is one more parameter that we quite commonly use in our lab actually, and they are the percentage of microcytes called micro R versus and the percentage of macrocytes called macro R. Anything that is above 10% of micro R would indicate that there is a microcytic population in the sample. And if macro R is above 6 to 8%, that would also indicate that there are macrocytes in the population. Now in this sample, you can see that there were almost 15% microcytes, which indicates definitely microcytosis was there. So it just reaffirms our understanding of this histogram by giving us these numbers. And again, another case. Now here the peak is not that of dimorphic. It's a single uniform peak, well formed. But if you see, it's a microcytic peak because it's an MCV of 65, a high RDW. And here the micro R, so almost 50% of the red cells were microcytes, which indicates that this is a microcytic anemia. Now another poll. Showing you a case, and I've highlighted some of the abnormalities. The RBC count is, this patient has just walked in for a health check, 36-year-old female, RBC count of 1.7, quite low I would say, but hemoglobin is 12. The hematocrit does not seem to match with the hemoglobin. MCH and MCHC are abnormally high, not usually identified in human blood. So, what are the possibilities? Is this dimorphic red cells? Is this RBC agglutination? Could this be a clotted or a hemolyzed sample, or is this macrocytosis? Okay, so I can see
Maximum have given ma'am number 2.
number 2,
Yeah,
and
and
it would be correct. And this is not really a clotted or a hemolyzed sample, although we are seeing a hemoglobin hematocrit error, if you see over here, but you're also seeing the pseudo macrocytosis and a little peak over here. And if you see, the RBC count is disproportionately low. It's too low for a hemoglobin of 12, and all the other parameters, let's say the platelet histogram seem to be okay, you know, and the WBC seem to be all right. So no other flags coming in. So this was actually RBC agglutination. Now my question to you would be, what do you do next? You have RBC agglutination. Would you release this report with an, with a comment? Would you ask for a fresh sample? Will you reprocess the same sample on the analyzer just to confirm the values? Or would you incubate the sample at 37 for 30 minutes and perform a repeat CBC? Yes, now we're getting pretty much uniform results. You're
Yes,
right,
ma'am.
it is incubating the sample at 37 degrees. Now, if we incubate the sample at 37 degrees, I would like to show you our values. RBC count got corrected, the hematocrit increased to 37, the RBC histogram lost that additional peak that it was having. The red cell indices improved. This is just to show you the earlier values, just for your comparison and a better understanding. The RDW also improved, and I would say these are more accurate results. Considering that the sample, the red cell agglutination got corrected at 37 degrees, one can automatically conclude that this was cold agglutinin disease. Just another case to show you. A patient, an elderly a female with an acute coronary syndrome. Now, if you look at this sample, if you look at the CBC, you realize that there is just a mild leukocytosis, a normocytic anemia, and mild thrombocytopenia. If you look at the histograms, otherwise everything looks pretty okay. So under regular circumstances, this would not even require a peripheral smear, and the report could just go. Bearing in mind just one very important factor. Don't miss looking at the flags. The flag is showing you a parasitic flag. So IRBC is a parasitic flag. The analyzer uses multiple combinations and let's say a programming which helps it identify parasites when it flags an IRBC. And when we see the smear, we saw gametocytes and many ring forms of P. falciparum. Informed the clinician, who was aghast and said, the patient doesn't even have a fever. Are you sure? So the next best thing we could do was send us a fresh sample. We will recheck. What if there's a mix-up, So we got a fresh sample, showed the same results, and thankfully this patient got treated. Now going beyond the CBC, looking at the bone marrow is looking at the status of the bone marrow would be something interesting if the CBC can offer it, and yes, it can. Starting with something like reticulocyte count. So what are reticulocytes? Reticulocytes are let's say non-nucleated red cells, which are a stage before mature red blood cells. They contain RNA. And keeping that fact in mind, we try to analyze these cells. So they're a good indicator of the bone marrow activity. And it can, if we see a lot of circulating reticulocytes in the peripheral blood, it does indicate that the patient is possibly got active erythropoiesis going on in the bone marrow. So how do we analyze this? The channel that processes reticulocytes exposes the sample or dyes the sample with fluorochrome dyes, something called polymethylene. So it uses these fluorochrome dyes which are specific to stain RNA. So it stains all the RNA or the reticulated cells in the blood. And if you look over here, we plot that against side fluorescence light, which measures the RNA content, against the forward scatter, which measures the size of the cell. And if you see, the highest side fluorescence would indicate the maximum RNA content of the reticulocytes, and then it reduces to low fluorescence ratios, which will have the lowest amount of RNA. So this is how we count reticulocytes, and as you can see, the RBCs which are not containing RNA are completely negative on the site fluorescence. Why do we need an automated count? Why don't we just, enjoy our manual retic count? Why would we want to go the automated way? So number one, it's analyzing many more cells. So in a manual retic count, let's say you're looking at maybe 1,000, 2,000, even 5,000 RBCs if you're very sincere. But the analyzer can analyze somewhere close to 30,000 RBCs to give you a more accurate retic count. And it not only gives you the quantity of the circulating reticulocytes, it even tells you the rate of production, that is the response of the marrow to the anemia by immature retic fraction. Along with that, this RET-HE, which tells you the quality of the reticulocytes. How does it do that? It measures the hemoglobin content of these reticulocytes and is able to actually tell you the iron supply in the marrow. It is the earliest marker of iron deficiency and it is not influenced by inflammation. Now coming to leukocytes. As again Dr. Naveen explained, it's simple again, impedance versus scatter properties used together, but with the principle of hydrodynamic focusing, what the analyzer is able to do is it pushes sheath fluid with high pressure on either side, which pushes the cells into the central path, as you can see over here, creating a single cell suspension, and this allows every individual cell to get analyzed, releasing certain number of signals. We have the forward scatter, which measures the cell size. Then we have the side scatter, which measures the intracellular structures, the nuclear complexity. And then, as we had discussed earlier, the side fluorescence, which actually measures the amount of RNA in the cell. Putting all this information together, it creates a scatter plot. And as you can see, suppose we have x-axis being side scatter, which tells you the complexity or the intracellular structures, versus y-axis showing you the size, forward scatter. You see the cells which are lowest on forward scatter and side scatter would be your lymphocytes, followed by larger cells, again not very cytoplasmically granular, and the nuclear complexity is not too high, but one of the largest cells in this sample, the monocytes. And as the cells gain more granularity, they are the neutrophils, and then the maximum granularity in the eosinophils. So this is, this is a scatter plot from a Coulter instrument. This is a scatter plot from a Sysmex instrument. I have put them side to side only to show you that do not judge cells based on their color. Every instrument will demonstrate different information. So get comfortable with your scatter plot. This one shows blue to be lymphocytes, this one shows pink to be lymphocytes, and aqua to be neutrophils. So get comfortable with your analyzer. It's another analyzer stained by peroxidase, just to show you the peroxidase positive cells like neutrophils, eosinophils, separating them from the negative populations. Now, patterns of WBC scattergrams, we have already discussed the normal patterns where we know the lymphocytes, monocytes, and neutrophils fall in this area. Eosinophils have the highest side scatter. Going up, if we consider fluorescence, as the cells gain more fluorescence, which means they're either immature cells, they're reticulated cells, they contain some amount of RNA, so they could suggest that we are dealing with maybe a reactive population, an abnormal population, blast population, and we may need to, and above neutrophils, of course, the immature granulocytes. Showing you a few cases which will help you look at abnormal scatter plots easier. So this is a scatter plot. As you can see, the count is 1,65,000 and almost 90% lymphocytes. However, there's an asterisk against all the differential counts. That is because if you look at the scatter plot, where the normal lymphocytes are present, there is an expanded, very dense population, obviously because they're possibly 90% of these cells. The differentiation between lymphocytes and monocytes seem to have merged. You can't distinguish between the two. Maybe there are no monocytes. And the population seems to have gone almost a log higher on the side fluorescence, indicating that there is either a reactive or possibly even a neoplastic population here. So what do you do next? This is just to show you in comparison a normal scatter plot. This is where the lymphocytes lie, and this is how our sample showed it. I would go with making a peripheral smear. You can't do without that. And what we did identify was small lymphoid cells, many smart cells, in conjunction with 1,65,000 WBC count. This more or less favors a chronic lymphocytic leukemia, but one would have to confirm that only on immunophenotyping or flow cytometry. So another case of, again, if you see just a 10,000 count, but lymphocytes were almost 79% and absolute count of 8.4. And if you see this population, although it's well distinguished from the monocytes, but the population is going way up on the side fluorescence, which is definitely suspicious. Are we dealing with blasts? Are we dealing with very activated cells? We definitely need to find out, again, requiring a smear review. And here you see reactive lymphocytes. Now, why I kept this case is this kind of a scatter plot can mimic leukemia, and sometimes one would get confused. But if you look at the peripheral smear, this patient was dengue positive and he had many reactive lymphocytes in the blood. Another case, similar scatter plot, but a very different case. Now here, I'd like to show, again show you lymphocytes 66%, monocytes 28%. If you see the population on the scatter plot, it seems to have merged. You can't differentiate the lymphocytes from the monocytes. It's again going very high on the fluorescence. The flags are telling you that there are either abnormal lymphocytes, blasts, atypical lymphos, and a severe thrombocytopenia. So what do? Have to look at the smear yet again, and there again we see acute leukemia, blasts in the circulating blood. This is again an important fact to bear in mind, because every leukemia will not come with leukocytosis. The patient had only a 7,700 count. So don't go just by this factor. Look at the scatter plots, look at the flags, and then decide whether you need to make a smear or not. Another case, very expanded population with high site scatter, suggesting there is eosinophilia. And if you look at the peripheral smear, it confirmed that. Here I would like to show you the population above the neutrophil seems to be expanded, showing you immature granulocytes. So this is just for me to expose you to various kinds of scatter plots that one can come across in routine practice. Now, one important factor to remember is looking at the scatter plots and seeing maybe, I cannot say this case is a CLL or a dengue or an acute leukemia or an AML just based on pure scatter plots. So please remember, do not try to perform a Herculean task by trying to, dig deep into how to analyze blasts on these scatter plots. Nobody will give you a diagnosis of acute leukemia without seeing a peripheral smear. So it would be the most useful to make a peripheral smear and then go ahead with diagnosing the case. So smear is essential. Now, interfering factors, as you can see, a small population here on the scatter plot and on the RBC histogram, WBC histogram. This is called the ghost area, which is smaller than lymphocytes. Now, why would we have interference considering that RBCs have gotten lysed in this channel, but we have some lyse resistant cells? What are they? They're nucleated red cells, lyse resistant RBCs, platelet clumps, parasites, and fibrins. So all these can cause an interference and, let's say, interfere with your WBC count and differentials. Having said that, now analyzers have a separate nucleated red cell counting, staining and counting facility, where in olden times, I wouldn't say olden times, but in our older practices, we would make a smear, count the do the differential count the nucleated red cells with the formula, give a corrected WBC count and a corrected differential count, and then release the report. Now the analyzer does all that for you, and you may not need to go through all this manual stress. And why are NRBCs important? They are a useful indicator for erythropoietic stress or RBC disorders like thalassemia. Where are they evident? As you can see, NRBCs are present. If you look at the counts, they're almost 89% on an absolute of 3.7. And just to highlight, this is what they look like on the WNR scatter plot. This is how they look in the peripheral smear for some of you who may not have seen so many cases. Coming to platelets. So again, Dr. Naveen has very beautifully described the platelet counting principles, and I don't go into them, impedance versus scatter properties. Talking to you about the platelet histograms, the lower discriminator is a fixed discriminator at 2 femtoliters with a moving threshold between, let's say, 20 to 35 femtoliters to encompass larger platelets, giant platelets. So making sure that both the discriminators touch the baseline, you get a fitted curve, you can pretty much identify that your platelet count that the analyzer is providing is quite accurate. Again, I'd like to add that there is another fixed threshold at somewhere close to 12 femtoliters, which then separates anything on the right of that discriminator as large platelets. This is to show you another instrument which gives you, let's say, the scatter properties, where you're able to use low and high angle sites scatter properties to refine the platelet counts. Okay, this is again to show you abnormal histograms, such as these could suggest anything from large platelets, giant platelets, platelet clumps, microcytes, RBC fragments, and this is how they look in the peripheral smear. And coming to the last few of my cases. So if you look at the platelet count, it's 92,000, but giving an asterisk, and you see the platelet histogram, it's not really touching the baseline, and it's giving me a flag of platelet clumps. So the next thing I need to do in this situation would be make a peripheral smear, and we saw platelet clumps. So what do we do next? We should ask for a citrated blood sample and perform the CBC, where if you see the count it has gone higher. From 90 it's come up to 160, that's 1,60,000, and the platelet histogram also seems to have corrected. However, since it's still showing an asterisk and it's still showing me the flag of platelet clumps, I would like to make a peripheral smear and to confirm that the platelet clumps have totally, let's say, disappeared or largely disappeared, and the analyzer is giving me quite an accurate platelet count. But bear in mind that a citrated blood sample contains a certain volume of anticoagulant, and this creates a dilutional effect which needs to be corrected with a correction factor of 1.1. So your final platelet count should go with this correction factor, and so the final platelet count is 1,76,000. And what are the do's and don'ts for platelet clumps? So never try to count the platelets in a clump and give an estimate to your desperate physician who is, asking you or pressurizing you to just give me a vague platelet count. Do not try doing that, because there's too much of counting bias. It's going to be extremely subjective, and you may not be giving a true picture to your physician. Whether it's impedance, optical, or fluorescent platelet counts, they will all be inaccurate in platelet clumps. That is something we need to understand, and we need to clearly explain to our physicians before they start bombasting us about how your analyzer is inaccurate and it cannot give us a proper platelet count. Also remember that if they're insisting that the report has to be generated and they cannot maybe give you, or even the citrated sample contains clumps and it's not getting corrected, one has to ensure that these that you can release an analyzer count, but definitely mention in your comments that the actual counts may be higher than the counts provided by the analyzer, since platelet clumps are present and an accurate count cannot be provided at this point. We would need a repeat collection. And not only mention this in your report, because we have seen out of experience that sometimes our physicians may not read our comment. So we actually phone our physicians every time we see clumps and we're possibly asking for a citrate sample, because they need to know. It's always good to communicate. Another case, and if you see over here, thrombocytopenia, again similar. The upper discriminator has not touched the baseline. It's possibly not giving an accurate count, and the reason being probably giant platelets. Now, this is the area that we know is a difficult area, whether we are looking at, now we're looking at the histograms. So your 20 to 35 to 40 femtoliter area, where we don't know whether these are microcytes or these are large platelets. Are they overlapping? Can we do anything to overcome this interference that impedance is giving? It's never giving us these accurate counts, especially when schistocytes are present. So if you see, we can perform an optical platelet count, which again is similar. It's run in your reticulocyte channel, which means the sample is again exposed to fluorochrome dyes, staining the reticulated cells. And we know that giant platelets are nothing but reticulated platelets, which means they will contain RNA, which means they will come high on site fluorescence as compared to mature RBCs. So even microcytes, if they are present, they will fall lower down on the forward scatter, but they will never be high on site fluorescence because they are not reticulated or they do not contain RNA, as versus the large platelets which contain the RNA and they will fall here. So easily differentiable, a very good parameter to have in your analyzer if you have the option available, because it really simplifies these cases where we overlap between giant platelets and schistocytes, microcytes, etc. So that platelet count, the case I showed you earlier with the 75,000 platelet count actually got corrected to 98,000, and you can see the population here, which is the giant platelets. There is one more facility available by some analyzers, and it's quite popular actually. It's called the platelet F, or the fluorescent platelet count, where the sample is stained with platelet specific markers, and like oxazine. And these largely just pick up the platelet counts and give you a highly refined, quite accurate platelet count, I would say. They also aspirate a larger volume of sample, and this is so that it can give you a more accurate count. Showing you the same. The immature platelet fraction is actually derived from this fluorescent platelet count, and just to show you one case where we got 85,000 as the platelet count, but look at the histogram. One can definitely not rely upon this. And if you see the reticulocyte histogram, it's showing you this population here of large platelets, and it's also showing you some reticulocytes, but it's showing this big trail down to possibly microcytes or something else that's interfering. So we look at the smear and we identify schistocytes. Now, looking at the manual platelets, we identified that this platelet is possibly not truly 85,000, but it's somewhere close to 40,000. So let's run a platelet F to confirm this value. And when we ran the platelet F, rightly enough, the platelet count came to 45,000, and that was the report released. So again, bearing in mind that automated counts, they have a lower statistical error due to the greater number of cells that are examined, and hence have an added advantage as compared to manual count. So if your manual and your automated counts are pretty much matching, giving the automated count would be a better idea. And this is again just to show you the increased volume, a higher fluorescent intensity is your immature platelets. This is what measures your IPF, and the reference range being 0.8 to 6.3%. A high IPF indicates an active marrow, low IPF suppressed marrow, and it provides the clinician very valuable information regarding the mechanism of thrombocytopenia and how to monitor patients who have thrombocytopenia. So my take-home message would be there's an ocean of information in these analyzers, and 5-part analyzers are very fruitful true and high volume labs, and in cases which we are very abnormal looking cases. Smear examination is irreplaceable. Humans are smarter, but they come at a high cost and more time. So save your resources and utilize them appropriately is what I'd like to end with. Thank you very much.